Hello, everyone, and welcome back to What in the Vagina is Going On. My name is Kamo, and this is the Well Woman series. Today, I'm not alone. I am with Dr. Koketso, also known as Dr. Gynae Mom, a medical specialist in obstetrics and gynecology who received her degree at the University of Wits. I don't know how you survived that. You're going to have to give me tips on that one. And is also an avid speaker on holistic women's health, skillfully bridging the gap between women's health and mental health. Welcome.
Thank you. Thank you so much for having me.
Oh, it is a pleasure. We've been planning this sit down for a while now, and I am so happy to have you on this platform.
My absolute pleasure. It's my absolute pleasure.
Okay, so on today's episode, we are going to be diving into a topic that these days is a bit a hot topic around moms, right? Especially moms who are about to give birth. And that is C-sections, right? Better cesarean sections, better known as C-sections. We are covering what is their purpose, what are the why is it rising globally, right? Moms saying that they want C-sections, and what to actually ask for when it feels like a mom is being coerced into one. I don't like to use the word coerced, but we'll just say coerced in this instance, and how one can build that agency over their own birth experience. So I am really grateful that you are here to dive into this robust topic. Let's start at the very beginning. In layman's terms, can you explain what exactly is a C-section?
So, a cesarean section is an operation where we deliver the baby. It's an alternative way to deliver the baby as opposed to the baby being delivered vaginally. So, we cut on the woman's abdomen. We cut in a few layers to get through the uterus to deliver the baby through the uterus. So the baby doesn't go through the vaginal canal. The baby comes out via an operation, and it's an alternative birthing method.
So let's put it like this. What does cutting mean? Because I think a lot of women, they're like, oh, I'll be put under, I won't feel a thing, it'll be glorious. But actually, having a C-section requires a bit of mental preparation, right? So what does the cutting through actually entail?
So it's a major abdominal surgery. So you don't just wake up and decide you're going to have a cesarean section willingly, but trends are changing. And in private healthcare, women can choose to have a cesarean section. And most women choose it because for them, it seems like a convenient way. They're able to plan around it. But the cutting entails it's a surgery. So we take a scalpel before taking a scalpel. So I will explain it to you like how I would when I consent a patient. So I go out to the patient, I tell them, okay, we're doing a cesarean section.
Please.
And what this entails is we will go to theater. And when we're in theater, there's the pain doctor, whom we call the anesthetist, who takes the pain away during the procedure. So he can take the pain away in different forms. The preferred form is for the pain doctor to put an injection in your back to numb your body from your abdomen to your legs so that you don't feel pain. You may feel pressure, but you won't feel pain. So that's the pain aspect of it, the anesthetic. And once he's done doing that, you lay on the bed and then the nurse will clean you up. I take a scalpel, I cut through the skin on your lower abdomen. So we make a transverse cut on your lower abdomen. We cut it through the skin. We cut it through your fat layer and the other covering tissues we call fascia. We go through that tissues as well. We also separate your abdominal muscles to get through to the uterus. But as we do that, close to the uterus, there are other organs, including your bladder, your bowel. So other organs that are close to the uterus or next to the uterus may sometimes be in the way. We remove them, but they're at risk of injury depending on what we find in the abdomen. But if injuries happen for whatever reason, we call other specialists to come in to help us repair those injuries. It just means that you will have a longer hospital stay in terms of recovery. So after cutting through all those layers, we get them to the uterus. We make an incision, a cut on the uterus. For a term uterus, we can make another transverse incision onto the uterus to get the baby out, because
Yeah.
the uterus is a muscle, and depending on how far you are in your pregnancy, there's another muscle that forms. So it stretches up where it forms the lower segment where we usually cut, right? So that's the safest place to cut for term pregnancies. If you're having an emergency cesarean section in terms of a preterm birth, if that lower segment is not adequately formed, we may need to make a cut in the middle along the uterus. That just means that we just have to be cautious with your subsequent pregnancies, because the risk of rupture with a straight cut on the uterus is
Yeah.
more than what it is when it's a transverse cut. So that's what it entails, summary. And that's how I would explain to the
You
patient.
see,
I would
I
go on
appreciate,
to explain the complication. I'm wondering for me to go through the possible
yeah.
complications, because as part of
No,
planning a
don't go,
consent form, I let you know
don't
what
go deep into the
the complications.
complications.
But that's what the cutting entails.
Truly appreciate the step by step that you took, because there's this misconception that C-sections are an easy way out. And if you actually have the concept in mind, this does not sound like an easy way out. Nobody wants to lie on the bed and have their organs moved out of the way just to bring forth life, right? And it
Yeah.
baffles me, and I think I want to put this to rest, that a C-section is not an easy way out. And I think some people tend to say, Hore, no, you actually didn't give birth when you have a C-section. They took the baby out. It's not you giving birth. And they minimize what you had to go through. So I really do appreciate you going in depth with what exactly a C-section entails.
Yeah. Yeah, no, it's a major operation. It's definitely not the easy way.
But now we've seen, and you've touched on it a little bit, about how in private you can now choose it as an elective surgery. But we've seen that globally there is a rise in C-section rates, right? The WHO actually stated that while every effort should be made to provide a C-section to women who need one, right? Rates should sit between 10 and 15%. But in South Africa, currently, that's not the case. As you touched, it says C-sections accounted for, and this is just from 2020 to 2022, accounted for approximately 28.8% of the births. So that's well above the 15%. So I don't know. From your clinical background and reasoning, what do you think genuinely warrants a C-section? Are moms scared? I don't know. Does a C-section, are we saying I don't know. I'm trying to figure out what makes moms now choose it electively, and how do gynecologists, obstetricians, what role do you play in that? I think that's the best way I can put it.
Yeah. Yeah. So you spoke about agency. So with the agency comes with getting the right information, making informed consent. So you're making decisions from an informed place. But the reason why the cesarean section rate might be so high is you have to consider your resources, where you are in the world, within the community. Are you in a resource limited area, or resources are ubiquitous in your area or not? And looking at the preference, you take into consideration the preferences of the doctor, the preferences of the patient as well. But you have to consider also the legalities. The litigations are skyrocketing as well, and cesarean sections are considered to be more controlled because you are planning, you are avoiding the unknown of the whole labor process. You are limiting or mitigating against possible complications along the labor process. And there's also with limited resources, the monitoring can also be limited. So if you're not able to monitor a pregnancy or a labor process, people will elect to just do cesarean
Yeah.
sections. So in an undisturbed labor ward or in an under-resourced environment, people will plan for elective cesarean section. But with the limited resources, there's also limited theater time, right? So you have to consider where you and how risk averse is your gynecologist or the patient themselves. Do they want
Yeah.
to plan the birth themselves? Do they want to plan the birth? And in terms of the timing, do they feel like they'll be in more control when they elect for a cesarean section? So some people don't want to go through the whole labor process, the whole unknown. The long labor process can also be overwhelming and distressing, right? So not to say that a cesarean section is better than a normal vaginal delivery or vaginal delivery is better than a cesarean section. So there are also different reasons why women may have cesarean sections, like medically indicated cesarean sections, right? So there are reasons why they may
Yes.
medically
Yes.
indicated, but they are more, but what you're talking about is when patients now elect to have a cesarean section or when doctors would advocate for a patient to have a cesarean section. It's a matter of the planning, the time, the control, the legalities around the whole birthing
Mm.
process and the patient's preference.
Okay. I think you actually segued into my next question because now you spoke about the medically indicative C-sections, right? Indicated C-sections,
Yeah. Yes.
where
Yeah.
now, okay, let's just imagine this. So I'm a mom. I'm sitting there, my water, not my water broke, or I'm getting contractions. I'm sitting in hospital, I'm lying in bed, and it's 3 a.m. and I haven't progressed. And the nurse comes through and says, "Look, your baby's heart rate is dropping. You need to get a C-section right now."
Yeah.
In that moment, as a
Yeah.
mom, what should I be asking? What should I be asking? Because, firstly, when you tell me baby's heart rate is dropping, I hear nothing else. And I immediately say, woo,
Yeah.
save my child. But honestly, what should we be asking in moments where it seems like, okay, this feels like it's going to a C-section, but I still actually want to wait it out for my vaginal delivery?
Yeah. Yeah. I hear you. So I always take myself back to an actual scenario. So you're talking about a heart rate dropping. So I always try to imagine myself as the patient. What does that mean? And what can it translate to? So I will explain to the patient that and what the labor process entails and what happens to your body and what happens to the baby. So during the labor process, when you're having contractions, are literally the muscles of your uterus contracting, and when they contract against the baby to try and expel the baby out of the uterus, right? And imagine someone
Mhm.
squeezing you, your
Yes.
head, your whole body. So with the contraction, your head is getting squeezed, and with the release of a contraction, you get relief, and in getting relief your body needs
Yes.
to now catch up and recover to get enough oxygen so that you are stable. I always liken it to someone on a treadmill. You run, you increase the speed, your vitality gets tested, right? So there are some babies that can't withstand
Yeah.
labor, but it depends. What is the problem? Is the baby's position right? Is the corner around the neck? So there are things that can make a baby not withstand labor processes, right? But when you're outside, the baby is inside, you might not see it, or you might see on a scan, why are you not progressing? Is it because the
Okay.
baby's cord is around the neck, or the baby's too big? You have to find reason. So when the heart rate drops, it's because the baby is not recovering in the time they need to recover in terms of the contraction squeezing them and in terms of them getting enough oxygen. So now imagine your brain being depleted of oxygen. What happens? Your brain will suffer. And we don't want that. So
Yeah.
when the heart rate drops, it means that the baby is complaining. The baby is saying that I'm stressed. I won't survive this any longer. because I'm not able to keep up with the contractions against me. I'm not getting enough oxygen. So that's what it means. How much time do we have? We have to put
Yes.
everything into context. How far is the mom dilated? How far up is the head? Because at that moment, we need to expedite the delivery. And what is the safest delivery route at the time? If the head is on the perineum,
Yeah.
you have to help that baby. What is the best possible way to expedite the delivery? If the head is on the perineum, you can use other mechanisms, use a kiwi, use forceps, whatever you have to expedite the delivery. And if the head is high up and you still have a long way to go and theater's there, we need to get theater, right? So also it depends how long is
Okay.
the monitoring happening and the heart rate dropping. So there are patterns that we look on the machine in terms of quantifying the amount of stress and assessing the recovery process. So you can ask all of those things. How much time do I have? Can I call my family? Can I? So
Yeah.
you have to put everything into context. How are you in labor? What interventions have been done? And how accessible are your theater facilities? So all of that has to be considered before you can make a decision.
Okay. So
And you have to understand. Then you start
I
asking,
hear you
if I
saying,
delay the process,
yeah.
what's going to happen? Yes.
Yeah. Yes.
Yeah. So as I said, the
If
baby's
you
brain is
delay the
getting
process,
deprived of
what?
oxygen. Yeah.
Yeah.
So if the baby's brain is deprived of oxygen, you end up getting complications where you get cerebral palsy. So when babies are not getting oxygen to the brain, they can get cerebral palsy where oxygen is being deprived, the brain is being deprived of oxygen, and then the babies get delayed milestones, they can get spastic muscles, they can. So there are complications that come with that. And some babies, when they come out, they can have brain bleeds. So there are a lot of complications that can
Yeah.
happen. So that's how you get the cerebral
Okay.
palsy, babies coming out with brain bleeds and having seizures because their brain now needs to go into a resting phase, we cool down to recover and hopefully heal. But it can have long-term effects.
Yeah.
So in that moment, you need to decide, do I want a healthy baby or do I want to risk it and have a disabled baby that I should be taking care of all my life? But you always have to weigh the benefits and the risk and put this
Way
into
out.
context.
Okay. I think my brain right now is going through a million questions, but I don't want to dive into the rabbit hole further. But I
Yeah.
agree with you. Definitely context is important, but I've also seen moments where waiting works out. And I think that's where let's do this. Let's say this. So when I think you are part of the antenatal classes. You offer antenatal classes which are free for moms. When they come there with their anxiety, now I'm going to bring a bit of mental health into the topic. When they come there with the anxiety of, but when and how do I really know? And I know you just told me that, no, you must ask the questions and get into the context of it. But when sometimes you can tell for a no man, I feel like my doctor is just moving towards that direction and my preference is this direction. Do you stand up and lead? Are patients empowered to stand up and lead from what you have seen?
Yeah.
Or are they mostly
Yeah. So when we see patients, I consider the patient doctor relationship to be a collaboration. And I'm not here to dictate, but to give the best possible advice. And I have an open door policy, and patients are welcome to get second opinions. But with what I know and what I practice, what I've seen with my experience, I can advise. And when I'm not comfortable with something, I'm more than happy to give a referral, right? Because at the end of the day, if a
yeah,
patient goes against my advice and something goes wrong, it comes back to the doctor where you get sued or you get blamed
yeah.
for stuff. So, as much as it's a two-way relationship, the doctor can decide to whom they treat, how they treat, and also give referrals to patients who prefer alternative treatments, right? We have to be safe and
Yeah.
We have to be safe practitioners first and foremost, right? As much as there's an idea that some
Mhm.
doctors may be pushing for cesarean section or coerce patients into having cesarean section, patients have the right to seek a second opinion, right? And some doctors I've seen and
Yes.
from a place of fear of being sued, or depending on what the follow-up process
Mm.
is, has been with the patient engaged. Okay, this one may be able to withstand labor, this one might not be able to withstand labor, or there are red flags when I do the ultrasound. On
Yes.
ultrasound, I've seen a cord around the neck, or I can only give advice. And the easiest advice for me to give is the medically indicated
Yeah.
cesarean section. So mothers who had previous cesarean sections or who
Mm.
have uncontrolled medical conditions, who are bleeding in an emergency situation, I'm very comfortable to say, Prop Jock, we need a cesarean section because it's the safest mode of delivery for both mom and baby, or for either or, right? So I can give you advice. But if you go against my advice, then it means I can't operate from a place where I feel disadvantaged, or I feel like I'm not going to give you the best possible care.
Yeah.
At that point, the consultation, I'll be more than willing to refer you for you to have a second opinion. Because sometimes when you are in a
Yes.
situation where you are in the labor, you are in labor and you feel like you want to deliver normally, and I can see that I'm going to run into trouble, right? In that setting, you're already in the labor process.
Mm.
Obviously, I'm not going to necessarily refer you. You will have to legally write down that you understand what I have explained to you, the reason
Yeah.
for the cesarean section, and you accept the possible risks and complications that may come with you going against my advice, right?
Yes.
But then it becomes a gamble then on you as the
Yes.
patient to say, I'm willing to risk this. If it's on you, you've written down on paper and you understand the
Mhm.
risk that comes with you pushing for a normal delivery, whatever complications happen, I'll be there to pick up the pieces and help you however I can. So long as I have explained to you and you understand and you are of sound mind, you need to write it down and sign so that come
Yeah.
what may, be there complications or not, and it does not fall back on the doctor. Some people are lucky, yes, the delivery may go smoothly. But most of the time, when a Caesar is indicated, there's a reason, right? So if patients are willing to take the risk and go against
Yeah.
an advice in the labor process, I get them to write down and sign so that if there are any complications, then they understand that the doctor did what they should have done or could have done. I understood and I decided to take the risk at my own accord with my sound mind, and I signed. So then the
Yes.
patient can't come back to me and sue me and blame me when complications do happen. So it's not everybody that becomes lucky, right? So there's a slight chance that the delayed progress might happen. But what delayed the because if there is a delayed
True.
progress of labor, maybe the baby's big, right? The baby may eventually come out
Yeah.
after a very long
In
time,
my case.
very tired, and having torn your perineum because the baby was forced out. So now the complication is you tore your perineum, you still need to go to theater. I still need to suture you because you elected to push out a 4 kilogram baby out.
Which was what I was going for, Dr. Pule. But okay, but I loved what you said that, and I think this is something that's not always spoken about, and that is that the relationship between doctor and mom, in this case patient, is a collaboration. And I think something that is missing within our healthcare system is shared decision making tools that can actually help moms or all patients actually get to a point where they ask questions and they are comfortable in the decision that they are making. Because sometimes, honestly, I don't think, having stood in both the clinician side and the patient side, I can say that sometimes you think you know, but you don't know, and you don't have the right questions, or you might not be able to formulate the questions well enough to ask and be comfortable in the decision that you're making. But I absolutely agree with you there 110%. So now you also touched on something about previous C-sections. I want us to talk about VBACs. What are
Yeah.
VBACs and who's eligible? And what are the risks or the benefits of a VBAC?
Yeah, yeah. So VBAC, using an acronym, it's a vaginal birth after cesarean section. So we allow VBACs for patients who've had one cesarean section. That's at least about 18 months apart to allow for the cesarean scar to heal. Okay. If you are within that time frame, you can attempt a VBAC. Anything beyond one Caesar or looking at your placenta. So I've told you can VBAC. Someone who had one cesarean section, provided that the scar was also transverse on the uterus, right? Remember, I said when the uterine incision is straight like this, the risk of rupture increases. So if you've had a preterm birth cesarean section, likelihood is that they might have done like a vertical cut of the uterus. You're not eligible for a VBAC, even if it was the one Caesar, right? And so
Okay.
and one Caesar, 18 months apart, then we can give you a VBAC, right? That's it. So, but the baby's breech, you can't VBAC with that one Caesar. And depending also on the placenta location, if your placenta is too low down, covering the birth canal, then you can't VBAC. If you have other medical
Okay.
complications, you can't VBAC. If you are bleeding, you can't VBAC,
I think
right?
that's
But some
interesting. It's one
people do
of the
try.
areas where I advocated for a VBAC. Sorry, Dr. Pule, what
Yeah,
did you say?
yeah. I'm saying that some people want to try their luck. You can't want to VBAC a baby who's breech. You can't VBAC when you're bleeding. And if during your VBAC you start bleeding in the abort mission, you go straight to theater. But some people like to push, like they push. I had a patient who was very pro VBAC and she had a Caesar literally last year, like 8 months ago. And I'm like, I don't want to gamble with my life or your baby's life. Or, yeah, you might be one of those lucky few who get away with it. But if I go with you through that labor process, my heart is here in my chest. I'm holding it like this and praying it does that.
Yes.
So uterus does not rupture. So I will not do that.
Yeah.
Some people are more brave than others, but I have seen too many complications in my lifetime from people
Yes.
rupturing their uteruses, having babies float in the stomach, stillbirths from people who have pushed for VBACs when they were not indicated. And you can lose a baby's life, you lose the mother's life. So I'm not willing to lose that. But
Yeah.
some people are brave. I'm not. And we get so attached to these moms and their babies. I'm putting the hard work. Why would I want to risk it at the end? No.
Yes. Yes. Oh, so true. So true. Okay. Let's move to the functional considerations. Now, what are the functional considerations following a C-section, right? Because usually we know that we get referred to a physio sometimes, a podiatrist here and there. But as a rehab person, as a rehab specialist, as an occupational therapist, there are things where I'm like, yo, I need help. But then I remember this particularly. The midwife will come through in the morning and say, "Mm-mm, you're still sleeping at this time. Wake up." What should we consider once we decide that, okay, or once the choices are beyond our hands, that we are having a C-section? What is the functional consideration that we need to put in mind?
Okay, so pregnancy is a process, an 8 to 9 months process, depending on when you give birth. But it's a process that happens over months, and there are hormonal shifts that happen during the pregnancy. Your center of gravity changes, your pelvic muscles, your ligaments, your body is changing throughout the pregnancy to accommodate this growing baby, right? So even after having a cesarean section, which is a major operation, we encourage early mobility because it helps with healing. It helps with the prevention of forming blood clots after a major operation. So we involve the physios and the OTs very early on. As soon as you are in the ward, the following day, we remove all the lines. The IV line must come out, the catheter comes out, you start mobilizing, getting out of the bed because it helps with the recovery process. This is now the physical process. As much as you don't
Yeah.
want to get out of bed, it really helps, right? Your gut starts moving, you're able to get the bloating out of the way. You start your diet very early on. You start so early mobility helps with the recovery and preventing blood clots, right? Some people throughout their pregnancy may
Mm.
use back support or those belts that support the belly because sometimes when you are a small petite person, the belly can hang and be very heavy and strenuous on your back. So we involve the OTs
Yeah.
and the physiotherapists very early on after recovery. But recovery is not just the time you are in the hospital. It took 9 months to grow this person. So even after being discharged at home, you still need to know that you must be mobile. And if you're still struggling with the aches and pains, go back to the physio, go back to the OT because it's a gradual process that's not going to happen overnight. People's shoe sizes will change, their arch of their feet will change because of how the ligaments are changing, your center of gravity changes, the weight changes, can weigh a lot on a woman's body. So whatever help you need, we
Yeah.
give you that help. But early mobility is very important. And if you're struggling with it, our allies are always there to assist. And that's just the physical part. The hormonal shifts also play a role. It's a whole lot of stuff. So in terms of your healing, you need to give yourself grace because it may take some time. And your ligament, you may not be able to do the moves that you usually did before pregnancy at the gym. Forgive yourself. But if it's ongoing and you start getting chronic pains and
Yes.
aches, the physio OTs are always there to help. You guys do a wonderful job. I don't know how many times I go carpal tunnel syndrome, but yeah, carpal tunnel. But yeah, my physios and
And
OTs are amazing.
what? Yeah. Okay. Now, thank you so much for touching on that. And this is not to say nurses come and wake us up in the morning. It's necessary. So this is just to show that when moms are
Very
complaining that,
scary.
oh, the nurse didn't give me time to sleep, it's because it's necessary for your recovery. Okay. All right. So
Yeah.
now I want to bring something to the table that was on the social media, and it's a case that where a mom in the US was brought before a judge, right? Because she
Mhm.
was refusing a C-section. She had three prior C-sections, which already now, from the education that you've given us, that already disqualifies her, right? But she was one of
Yeah.
those who wanted to attempt a VBAC and avoid a fourth surgery. But the hospital staff disagreed and citing that there would be a uterine rupture. And when she refused to give that consent, the they filed a petition. The hospital then filed a petition, and there was a virtual court hearing. Mind you, she's in active labor. There was a virtual whole court hearing with she had no legal representation, but and initially the judge ruled in her favor. But later that night, the doctors reported that the baby's heart rate was dropping, which obviously then ended up in a C-section, right? But now this, for me, made me think about bodily autonomy, right? The right
Yeah.
of pregnant women, patient or person to direct their own medical care, but also about what maternal health disparities exist. And we don't speak about them that much in our country, I think, but they are there, right? They are there. How would you encourage moms to take agency over not only their own journey, but their bodies, especially when now they have to be brought to court? I felt like that whole
Yeah.
scenario was
It's not
a little bit
necessary.
unnecessary, but necessary because it was shining light to gaps that exist. Yeah, how would you do
Yeah.
that in a in
Yeah.
context of South Africa?
Yeah. Attending antenatal care is important, and your birth plan is not a plan you make on the day you deliver, right? So if you come to me, you have a previous cesarean
Yes.
section times 3, we are sitting down, we are building rapport, we are building a relationship, and then there's patient education. Whole relationship, educate. I can't educate you. I don't have a relationship with you, right? So if I build a rapport with the
Yeah.
patient, I educate them. You will have a whole 8 months to do that education. And if you will establish by during the antenatal care consultations, the intention of the mom, how she wants to deliver, and you can try as much as you can to educate. But when patients are not willing to receive, how are you
Yeah.
communicating? Is it still a collaboration, or am I coming down at you with a paternalistic attitude? And if the patients want more information, there are websites, there are articles, there are guidelines everywhere that we can go through and read.
Yes.
With the previous design section times 3, we are not deciding on the day that how your mode of delivery.
Yes.
On that first consult, I'm telling you, you are not doing a VBAC. There's no VBAC. And if you don't agree with me on that day, I'm happy again to write a referral for you to go deliver elsewhere so that when the day comes, you and I are not in a tug of war, because I'm not comfortable with doing a VBAC on a patient with a previous cesarean infection. See how it's a collaboration? You can come and tell me what you want, and I can tell you
Yes.
what I can offer. And that which I can't offer, I'll refer you elsewhere, but I'll give you the right information. If I need to give you the right literature as well, I will refer you to the correct website, links, and guidelines. I'm happy to do that. But I will also not be coerced in doing something that I deem unsafe, the same way patients say that they're being coerced. I myself, as a medical professional,
Yeah.
will not be coerced into doing something that I'm not comfortable with. But patient autonomy is very important. But autonomy comes with also being informed, right? And we, at the end of the day, patient autonomy is very important, right? As I said, if I meet with you and we
Yes.
are in the labor room, yes, you will sign, you will take that risk if you rupture. I will save your life if I need to save your life. So long as you are of sane mind,
Yeah.
you have written with your handwriting, you have signed, then that's if you're in active labor. But if I'm seeing you for 9 months and we're having a conversation about you delivering normally with 3 Caesars,
Yes.
I would refer you somewhere else. I will refer you somewhere else because I'm
Mm.
not coming at 3 a.m. for previous Caesar times 3 labor for saying to have a
Yeah.
VBAC.
What I loved about your answer is that you boiled it down to educating. And I think a lot of what's missing, and now I'm taking it away from pregnancy and being a mom, is the education of our own bodies from a young age to actually speak up when things are changing in the body. Are we even comfortable with speaking about that or getting us help? We tend to live with so much pain and illness before we actually go and seek help. And by that time, it's sometimes a little bit too late. Sometimes you catch it early on. But it all stems from how are we body literate? Are we actually even
Exactly.
body literate to know when to seek help? So I love that your
Yeah.
answer really boiled down to we need to educate. And yes, in this instance, as a mom, you need to be attending your antenatal so that you can be educated about your options and so
Yeah.
that you can
Yeah.
ask the questions and be ready and be prepared. Let's talk about the mental health side of it. How do you prepare your, and this is the last question, I swear. What do you empower your moms to do regarding their mental health during pregnancy, during whatever route the delivery may go? What lasting words would you leave for moms actually across the board?
So I always advocate for support systems. One, pregnancies can vary, are different from person to person. So I always advocate for a support system. A support system may be your neighbor next door, your parents from home, your sisters, your friends. So you must always have a support system because you go through ups and downs, dips, and there's a whole lot of hormonal changes. And also, education for me translates into empowering a mom. And when a mom is empowered and they understand what they are going through, they are able to make better informed decisions, which makes my job much more easier. So support system, asking questions, and are always, because people have different personalities. So depending on which trimester you're in, I always bring something new to speak about and to explore, to start conversations, because people will not ask questions. So I don't assume you know anything. I will go from A to Z with you,
Yeah.
whether or not, so that it opens conversations about other things that you may not know or understand. And it also gives me an opportunity to understand where you are as a person, because with your hormonal fluctuations, people can become anxious, they can become depressed. And if you do not suss out those symptoms during consultations, postpartum period also becomes very worse. So each trimester, I
Yeah.
do a mental health screen to make sure, because the person who's at risk is the first time mom, young mom, the mom who's a career woman alone in Johannesburg, the mom who comes alone to the consultation room, the partner has never come to the ultrasound, a mom with a family history of mental health issues. So you have to risk profile your patients, right? And
Yeah.
check in as you need to check in, because these things can be missed. You, just because someone walks into the consultation room smiling doesn't mean that everything is perfect, everything is fine. So prevention, I always say, is better than cure. Always for screening and prevention.
Yeah.
If there's a problem, we need to address it. And I'm always playing detective, unassuming. Okay, I'm always a detective, but I also try to see my patients as human beings that are part of a family unit. How are you? Family back home? How are your
Yeah.
two kids? And then we can suss out a lot of things and address them as they happen and prevent complications. Because once your mental health is not taken care of, you are at risk of having babies with low birth weight, babies that are premature, babies who
Yeah.
later have psychopathology and stuff. So, yeah.